Hello friends, now I'll be discussing you medicine questions of Grand Test 182. The medicine questions are from number 12 to 41 and I'm sure by now you have done all these questions. So let's talk about question number 12. True about multiple sclerosis. As the PGI, this is a PGI Chandigarh mock, so there are more than one right answer. The answer are true about, yes, steroids are used in the prophylaxis. Is used in, so let's talk about how we really treat a case of acute multiple sclerosis. So we treat a case of acute multiple sclerosis, acute attack. We treat by giving pulse therapy of steroids. And in this case, we give injection methyl prednisolone. We can also do plasmapheresis. We can also give intravenous immunoglobulins, but this is the most widely method. Well, as we know that in case of multiple sclerosis, recurrence is common. That's why we use many prophylactic drugs. The prophylactic drug, I'll discuss about newer prophylactic drugs. The older one are azathioprine, cyclophosphamide. The newer one are interferon beta. We also use mitoxantrone. We use glatiramar. We use natalizumab. Point to be noted where here we use interferon beta. In fact, it's the only condition where we use interferon beta, and it's one of the best drugs to use in prophylaxis in this case. Interferon alpha has got no role to play in this. So now if you look into the options that we have, that steroids are used in acute attack, yes, true. Immunoglobulin are effective method treatment, I told you. Interferon alpha used, no, we don't use. Interferon beta used in prophylaxis, plasmapheresis can be used. So hence answer is A, B, D and E. Let's talk about Swanganz catheter. Okay? Well, in this case, the answer is right atrial pressure. A, B, and C is the right answer. A, B, and C. So let's talk about Swanganz catheter. Well, when we talk about Swanganz catheter, it primarily measures right atrial pressure. Okay? And ultimately, it is going to do the pulmonary capillary wedge pressure. It's also going to check indirect measurement of left atrial pressure, because pulmonary capillary wedge pressure is the indirect measure of left atrial pressure also, right? And ultimately it will detect the filling pressure, left ventricle filling pressure, because it's going to measure left pulmonary capillary wedge pressure, which is the indirect measure of left atrial pressure. And just to inform you, in case of mitral stenosis, where there's increased LA pressure, that definitely going to increase pulmonary capillary wedge pressure. The answer is A, B, and C. Now we talk about question number 14. Tanzurate is seen in myxedema, nephrotic syndrome, and pulmonary embolism. Now let's talk about transudate and exudate. Well, when we talk about pleural effusion, we broadly classify into transudate and exudate. Here the protein is transudate less than 3 gram%. Here the protein is more than 3 gram%. Okay. Next, if you coagulum formation, that means you take out the fluid and keep in a vial, it doesn't clot, it may form the clot. Cells, it may have lot of lymphocytes. Lot of lymphocyte count is very, very high. Even cancer cells, malignant cells can be seen depending on what the cause of transudate. These cells are usually not seen. Now, classically we talk about cause of transudate we see in congestive heart failure, chronic liver disease and nephrotic syndrome, and hypoalbuminemia, also called malnutrition. In nutshell, any cause of low serum albumin level like this condition, they will lead to transudate. What's the reason? Let's learn the basic mechanism why transudate occurs in this condition. Wherever we have reduced serum albumin level, like this thing. Well, basic concept. The basic concept goes like this. This is the blood vessel. In the blood vessel, we have a albumin, A for albumin, which maintains the oncotic pressure. OP stands for oncotic pressure, and we know very well, with oncotic pressure, water will come to inside the blood vessel. Then we have water, which will throw out the water via hydrostatic pressure. Hydrostatic pressure. So now, in case of any cause of hypoalbuminemia, the oncotic pressure is reduced, but hydrostatic pressure is normal. So now hydrostatic pressure is more than the oncotic pressure. There is a relative increase in hydrostatic pressure. The water will leave the capillary, and that is the one which lead to edema of feet. Okay. So in fact, in the main cause of edema of feet in this case is always low level of serum albumin. Right. Let's talk about question number. So answer is, in this case, is A, B, and C. One thing more, in a pulmonary embolism, sometimes even exudate can occur, but still transudate is also a feature. Well, correct statement about combination of the fluid is absence seizure, we use ethosuximide, yes, this is true. And partial seizure, we use valproate, true. Myoclonus, we can use valproate. Febrile seizure, clobazam, but atypical absence seizure, this not valproate is the best answer. So in this case, A, B, C, D is the best answer. Now I must tell you the treatment of seizures. Okay, I'll make it a very simple table for you. Now I quote a table from Harrison 20th edition. The table goes like this. First line treatment, second line treatment. Generalized tonic-clonic seizure, generalized tonic-clonic seizure, focal seizures, absence seizures, myoclonic seizures, and others type variety. Well, first line treatment is valproate, V for valproate, then lamotrigine. Here, lamotrigine. Valproate, VA is valproic acid. This is summary that I gave to you. Well, we can very well see. Lamotrigine is the one drug that can be used in all varieties. Even valproate can be used in all the varieties, only the condition where second line treatment is focal seizure. That means the question will come to you like this. Which is the first line treatment of any one of these? Option will be either lamotrigine or valproate. One will be there, not both. So you can very blindly go for either lamotrigine or valproate. Now look at so tricky thing. Absence seizure, in absence seizure we all know we can give ethosuximide also. Okay, now in fact about 4 years back a question came in NEET exam also. The question was first line treatment for absence seizure. In that they talk about valproate, phenobarbital, phenytoin and etc. etc. They did not mention about ethosuximide. So friends, either valproate or ethosuximide will be there in the treatment of absence seizure. Even lamotrigine is not a very preferred drug, although as per book wise, lamotrigine is the first line treatment for all the cases, but in actual practice, clinicians do not prefer to use lamotrigine because one of the main side effects of lamotrigine is severe skin reaction. It can even lead up to Stevens-Johnson syndrome also. It's not a very popular drug in actual practice. But one more drug which is getting very popular nowadays is, especially for grand mal epilepsy, is topiramate. Why topiramate? One of the biggest advantage of this drug is it causes weight loss. In fact, this drug has been approved as a drug to weight loss also. For obese patient, this is an approved drug as an anti-obesity drug also. And valproic acid, which is a very good drug, which has got a wide range of action. But one of the side effects is weight gain, and I'm sure none of the young ladies will like to gain weight. That's why this drug is especially used in young ladies, and moreover, this drug is safe in pregnancy also. That's the other biggest advantage of using topiramate. Okay. Now we talk about Prince metal angina. Question number 16. Smoking is an important risk factor. Yes, smoking is always a risk factor for any type of coronary artery disease. Okay. Coronary artery can be normal in angioplasty, yes. Attack may occur in 12 midnight to 8 a.m., yes. ST elevation present, yes, and acetylcholine, all are true. So let's talk about this question in detail. Prince metal angina. So let's learn the basic concept about Prince metal angina, basic concept. The basic problem is there is vasospasm. There may be a atherosclerotic plaque nearby. It may or may not be there. And since the basic problem occurs due to vasospasm, so this is especially precipitated by those things which lead to vasospasm like cocaine and acetylcholine. Acetylcholine is used as a test to look for the vasospasm. And in this case, when you do the ECG, it is a normal ECG. But this is ST segment elevation is there, like this. And we know very well this type of ST elevation occurs in acute MI also. Now, I have a question for you. The question is, we get one patient who has acute pain chest and you get ECG like this, which indicates acute MI. But now my question is, how to differentiate that this is a case, it's not a case of acute MI and it is a case of Prince metal angina. What tests you will do to clarify this doubt? Stop the video, write down the answer. Write down the answer. Well, I'm sure you must have written the answer by now. Well, the answer of this question is what test to differentiate between two? Answer is go for cardiac enzymes. Cardiac enzymes will be normal in Prince metal angina and they are increased in acute MI, and troponin T test is the most troponin T test is the most widely used clinical test to differentiate between acute MI and Prince metal angina. Now one more very frequently asked question. What the first line treatment is? Again, we use nitrate. It's the first line treatment in this case. Of course, we use, remember, nitrate are the first line treatment even in case of Prince metal angina also. So-called sorbitate is the first line treatment. Okay. Well, now we talk about next line, next question. Chronic vomiting will lead to all except. Okay. So let's learn the basic concept, what it will lead to. Chronic vomiting will lead to what? Vomiting will lead to decrease intravascular volume, obviously. Decrease intravascular volume will lead to what happen? Let's see. And of course, as the vomiting is going out, it will lead to metabolic alkalosis. Two things will happen. Why metabolic alkalosis? Because body is losing hydrochloric acid, and that lead to metabolic alkalosis. But second thing is decrease intravascular volume. This will lead to what? This is a kidney nephron. So as the intravascular volume is reduced, the body will try to secrete more and more aldosterone, A for aldosterone. And this will, normally 2 sodium are absorbed. And since 2 positive particles have come in, normal I am talking about, 1 H ion will go out and 1 potassium will go out. This is normal. But in case of chronic vomiting due to increased excess aldosterone level is much more than the normal. So now let's presume 4 sodium have been reabsorbed. So now body will try to secrete double H ion, double potassium. Double H ion goes, that lead to, double H ion will go out, that will try to go for, as H ion going out, that will lead to what? Metabolic alkalosis. That is further the reason why metabolic alkalosis will occur in this case, and hypokalemia will occur. So we understood that why hypokalemia and why metabolic alkalosis will occur in this case. With this background, let's talk about options that we have. So as we are losing lot of liquid from the body, and that can lead to hyponatremia. Anion gap will not be increased. Anion gap is increased in metabolic acidosis. This will not be a feature. Metabolic alkalosis, yes, it will be there. Acidosis will not be there. Hypokalemia will be there. The answer here is A, C, and E. There's some typing error in the answer key. Please make some correction, necessary correction, because there is some error in the answer key. The answer is A, C, and E. Now we talk about question number 18. True about rhabdomyolysis. So let's learn about basic concept. What do you mean by rhabdomyolysis? Rhabdomyolysis is typically there is excess of muscle. In fact, this happens in muscle crushing, and this typically occurs during earthquake. What do you mean by this? Suppose an earthquake has occurred, and one person is trapped, and his thigh muscle are, and there's a big pillar falls on the thigh, and that he's not able to remove that pillar, and his thigh muscles are totally crushed. A rescue team comes after 6 hours. They remove this big pillar which had fallen on his leg. But in 6 hour time, his muscle is totally crushed, so-called rhabdomyolysis. So that will, since it's all protein, that will lead to large amount of BUN, large amount of creatinine will produce, large amount of lactic acid will produce, large amount of uric acid will be produced. But calcium get bound to the crushed muscle, so that lead to hypocalcemia, but there will be hypophosphatemia. Only calcium get this thing, okay? And now in this condition, one more problem that will happen is non-oliguric renal failure. Non-oliguric renal failure. What do you mean by non-oliguric renal failure? Patient may be passing maybe 1000 ml of the urine, but still the patient is not able to excrete all the waste. Why? Because the load of a solute, the waste is too high, and even 1000 ml is less to throw out all the waste. So we call it non-oliguric renal failure. And in these cases, in the urine there will be myoglobin will be there. Urine will contain myoglobin. With this background, let's look into answer key. Hyperkalemia will happen, yes. Hyperkalemia will happen. Hypercalcemia, no. Creatinine, yes. Hyperuricemia, all will be there, and hypercalcemia will not be there. Now, just to simplify the subject, the lab finding of rhabdomyolysis are exactly same as what we get in the case of chronic renal failure. What we get in chronic renal failure? We get hyperkalemia, hypocalcemia, increased urea, creatinine, increased uric acid, and lactic acid is there, and of course, another finding that we get is increased phosphate. So just to simplify the material, that the finding of lab finding are same as what we get in CRF. Question number 19. True about rheumatization is A, B, and D. A, B, and D are the answer. Fusion and shortening of chordae tendineae in mitral stenosis, that's why area get reduced. What is the normal area of mitral valve? 4 to 6 square centimeter. When this cusp get fused, the area get reduced, and the symptom, when an average I take as a 5 square centimeter. Now when the area goes to below 2.5 square centimeter, patients start having symptom of mitral stenosis. Well, there can be, what else can be there in these patients? Patient may have calcification of mitral valve. Well, how do you know that patient valve has calcified? Normal in mitral valve, S1 is loud. But when the valve is calcified, S1 becomes soft. And moreover, when the valve is thickened and non-calcified, opening snap will be there. But once the valve is calcified, opening snap will disappear. Annular involvement is a feature that contributes to mitral stenosis. Aortic dilatation is usually not a feature because there's nothing to do with the aorta. In fact, the amount of blood coming to LV is reduced. So that definitely amount of blood going to aorta will be reduced. So there is no reason why aortic dilatation can occur. So answer of this question is A, B, and D. Now we talk about question number 20. Okay. So 20, we just discussed the question. In question number 20, false about deep vein thrombosis, prophylaxis. Abdominal surgery for malignant disease and high-risk patient. In such cases, we always give prophylaxis because deep vein thrombosis is the one problem which can dislodge and go to and can lead to pulmonary embolism in around 10% cases. So we give prophylaxis, always give. All patients in age more than 40 years. Well, this is total false. Why should give in all above 40 years without any reason? This is again false. This is true, this we give. This is false. We don't give in all patients unless there is some indication. What are indication? Patient is lying on the bed for a long time. Systemic heparin is only method of DVT prophylaxis? No, this is false. It's not a false. Best is movement. Leg movement is the best. Patient undergoing major surgery? Yes, true. 10% of the may go into pulmonary. This is also true. So false here is B and D. Okay, B and D. Again, there is some typing error in the answer key, so answer should be B and D in this case. Well, little extra knowledge for you. Pulmonary embolism and deep vein thrombosis. Extra knowledge for you. The pulmonary embolism 70% come from deep vein, 30% come from pelvic vein. And the common predisposing factor for deep vein thrombosis is any condition which lead to prolonged bed rest. Prolonged bed rest. Like after abdominal surgery, orthopedic surgery, postpartum. In addition to that, coagulopathy and factor 5 laden mutation. And this one which lead to only venous thrombosis. Now come the question to you. Stop the video, write down the answer. Suppose the patient has the pulmonary embolism. What is the most common symptom? Write down the answer. Well, I'm sure you have written the answer. Answer is sudden onset of dyspnea is the most common presenting symptom of pulmonary embolism. Patient can have pain chest. Patient can have hemoptysis. Patient can have pleural effusion. It's the most common cause of acute right heart failure. And in this case, even syncope can occur. Sudden death can occur in this patient. Okay. Question number 21. A young female has pain abdomen, constipation, irregular talking, BP, hypertension, and Watson short test is positive. What should not be given? This is the one clue that goes toward a case of porphyria is Watson test is positive. This is positive in acute intermittent porphyria. Well, we know very well there are so many drugs which can precipitate porphyria like valproate, alcohol, gosofulmin, and danazol. So propranolol is the one safe drug for this patient. And out of these, this is the most important thing that you should remember, which can precipitate acute intermittent porphyria. Now let's learn something about acute intermittent porphyria. We know very well it's a disorder of heme synthesis. Classically, patient come with pain abdomen. Patient has a ascending paraplegia. Okay, muscle weakness can occur, and patient can have psychiatric manifestation. Patient can have autonomic dysfunction. Patient can have hypertension also. Right? So one of the important specific treatment of this condition is avoid the precipitating factors. Question number 22. We get a IV drug abuser. He has fever, bilateral lower lobe consolidation, and probable diagnosis is, well, classical answer of this is this, B Bombay. Well, we all know that when we use IV drug abuser, this can lead to endocarditis. Most common valve involved is tricuspid valve. And in this case, the most common organism is Staph aureus. Right? And the most common valve involved in native valve endocarditis is mitral valve, native valve. Native valve endocarditis is mitral valve. And most common endocarditis occurring in the aortic valve is prosthetic valve. Prosthetic valve most commonly involve aortic, and native valve is mitral, and the IV drug abuser is tricuspid. In the mitral valve, the most common organism is Staph aureus. In prosthetic valve also, in early stages, within 2 months is Staph. But after 2 months, this is Staph epididymis. Okay? And of course, in IV drug abuser, Staph aureus is the most common valve. So look into option. Mitral valve endocarditis due to Staph viridans? No, this is not a feature of drug abuse and endocarditis. Tricuspid Staph, yes. TB is not a usual presenting in IV drug abuser. Pneumocystic carni is again, it is usually seen in immunosuppressed, not in IV drug abuser. Vaginal granulomatous has a different presentation. It has got triad of upper respiratory tract involvement, which come as a nasal discharge, lower respiratory tract involvement, that come as a hemoptysis, and there is renal failure. Okay, especially what type of glomerulonephritis we have? Crescentic glomerulonephritis. And here we don't have any such picture like this thing. The best answer of this case shall be tricuspid valve endocarditis. Next question, number 23. A 24-year male come with the altered sensorium, rapid shallow breathing, ABG shows 7.2, that is acidosis. His bicarb is 10, sodium 140 and 98. Okay. This is a case of classical case of metabolic acidosis. Why? Because bicarb is low. And we all know very well, if bicarb is low, that indicates metabolic acidosis. True. And it is supported by pH less than 7.4. 7.2 indicate metabolic acidosis, low bicarb is 10. Now this has a rapid shallow breathing. Now stop the video, write down the answer. What is this breathing known as? Write down the answer. Well, this is so-called Kussmaul breathing, also known as acidotic breathing. And this is due to, it's a compensation because a large amount of metabolic acidosis, very high amount of acid is there in the body. Body will try to wash out CO2. CO2 is a acidic gas. The body will try to wash out acid in the form of CO2. Now let us see how much the anion gap in this case. Anion gap we calculate by sodium minus chloride plus bicarbonate. Okay. Now if we have to look into this condition, the sodium here is 140, 98 is chloride and bicarb is 10. So we are 140 minus 11108. So anion gap what we are getting is 32 in this case. Normal anion gap is 6 to 12. Now if you have to look into causes of increased anion gap is seen in certain disease like DKA. It can occur in renal failure, acute and chronic renal failure, lactic acidosis, prolonged starvation. It can also occur in certain poisoning like salicylate poisoning. It may also occur in ethylene glycol poisoning. Ethylene glycol poisoning. EG stands for ethylene glycol poisoning. It can also occur in methanol poisoning. So now if you look into the questions, in this case we got increase in anion gap, and increase in anion gap is seen in DKA and ethylene glycol poisoning. The answer shall be B and C. In RTA and amphetamine toxicity, it is normally anion gap is normal. Question number 24. Sudden onset of distress is there, and BP is 90-60, loud P2 is there. What is the condition like? Sudden onset of dyspnea with tachypnea with loud P2, we are talking about acute pulmonary embolism, which lead to sudden increase in pulmonary arterial hypertension that we manifest by loud P2. Sudden onset of tachypnea is what we can think about is pulmonary embolism. So in this case, we should do D-dimer test is done. Is one condition, which is one of the very easy screening tests, the D-dimer is positive in these cases. Saturation is reduced, not increased, because the pulmonary embolism is there. In pulmonary embolism, oxygen saturation is reduced. And in ECG, I'll discuss this ECG just now, we get S1Q3T3. Streptokinase thrombolysis can be done in massive embolism is there. IV steroid have no role to play. The answer shall be A, C, and D. But I'll definitely like to talk about ECG finding in pulmonary embolism. So, ECG finding in pulmonary embolism. tachycardia is the most common finding. In HR means increased heart rate is the most common finding. But if they ask you what is the most characteristic finding is S1, Q3, T3. What do you mean by S1? In L1, you get S wave in L1. This is the S wave. Q3, T3, this is L1. Then you get Q wave and T inversion in L3. So what we get is S1, Q3, T3, Q wave and T3 inversion in L3. What else can be there? There can be right bundle branch block. Right bundle, how does right bundle branch come? It comes as, this is V1, V6. We get M pattern in V1 and R pattern in, and W pattern in V6. That we get in right bundle branch block. With this background, if you look into the options, so options are, we get S wave in this thing and Q wave in L3 is there, right? Now I have one question for you. Stop the video, write down the answer. I told you that ECG finding, whatever is there, I have told you. Now there can be one more ECG finding. Stop the video. This is a rank number 1 getting question. What else can be there in case of ECG finding in pulmonary embolism? Stop the video, write down the answer. Well, I'm sure you have written the answer. The one more finding that we can get in these cases is rank number 1 question. Answer is bradycardia. Bradycardia. It is true that tachycardia is the most common finding, but in some cases bradycardia can be there, and that is known as paradoxical bradycardia. Paradoxical bradycardia is rank number 1 question. Hyperkalemia is caused by Gordon syndrome, caused by cyclosporin also. In rest, these conditions you get hypokalemia. Okay. Well, let's talk about what are the findings in Gordon syndrome. Okay. Let me give you a beautiful chart. This is Bartter syndrome. This is Gentleman syndrome. This is Liddle syndrome, Gordon syndrome. Potassium level, reduce, increase. Metabolic, alkalosis, acidosis. BP, normal, increase. That means hypertension occur in Liddle and Gordon. Okay. The serum aldosterone level, increase, decrease. It's a beautiful summary of the 4 channelopathy that operate in the nephrons. With this background, we talk about hyperkalemia. Hyperkalemia occurs in Gordon syndrome. In addition to that, even cyclosporin can lead to hyperkalemia, and all these they lead to hypokalemia. Hence, the answer is A and E. Glioblastoma multiforme true is, it's the one tumor which usually occurs in 6th decade. What is glioblastoma? It's nothing but the most malignant variety of astrocytoma. I'm sure all of you know there are grade 1, 2, 3, 4 about astrocytoma. Grade 1 astrocytoma is more of a mild, is a benign or slightly malignant. But as we move from grade 1 to grade 4, is malignant tendencies increased. Grade 4 is nothing but glioblastoma multiforme, which is a highly malignant tumor, and it has got a very poor prognosis. It's mainly supratentorial, and it has a it's supratentorial, not most commonly in posterior fossa, and it's a very bad prognosis because it's a highly malignant tumor. The best, so answer shall be B and C is the best answer. What's the treatment of this condition? You mainly go for surgery. You have to remove it, but recurrence is so common, that's why it carries a very, very poor prognosis. Regarding third Hertz sound, let me discuss the basic concept. Basic concept, third sound, basic concept. Let us see how third sound is produced. For that we talk about cardiac cycle. CC is normal cardiac cycle. This is the heart, and this is the mitral tricuspid valve and mitral valve. When diastole starts, these valves open. Rapidly blood enters the ventricle. In the initial stage, in the rapid filling phase, around 70% of the blood enters the ventricle from LA. And this valve open, blood come, and in the JVP you get wide descent. The wide descent is produced in the early diastole. In the left side, normally there is no sound is produced, but if a sound has to produce, it is third sound. So third sound is produced in the early diastole. That's why this is also known as filling sound. Filling sound, early diastole. And now I don't need to tell you that Y wave corresponds to S3. S3 is a low pitch sound. And all low pitch sound we hear best with the bell of the stethoscope. Okay? Well, near the end of diastole, this atria will contract, and they will push another 30% of the blood into the ventricle. But this will be by active atrial contraction. So that's okay, this is active. So now when this on right side, due to atrial contraction in JVP, A wave will be produced in JVP. On the left side, normally no sound is produced, but if a sound has to be produced, it will be S4. That's why S4 is also known as atrial sound. Atrial sound. Remember, atrial sound is produced due to active contraction of the atria. So this is active, or rather you can say late diastole is an active process. Early diastole is a passive. Why passive? It is just being produced because of ventricular dilatation. There is no active contraction of atria. So that's why early diastole is a passive process and the late diastole is an active process. So now I don't need to tell you that A wave will correspond to S4, and during atrial fibrillation, A wave and S4 both will be absent, and during atrial fibrillation, the amount of blood coming to ventricle is reduced by 30%. For 30% of the blood will not be able to come to the ventricle, and that means in the next systole, amount of blood entering the aorta will be reduced by 30%. And since there is no active contraction, there will be stasis of blood in LA that will lead to thrombus formation also. With this background of basic concept, let's talk about third sound heard in, and of course, third sound can be heard in normal in children. Write down, it can be heard normally in children, athlete, and pregnancy. Physiological. S4 is never physiological. More point. S3 can be heard in mitral regurgitation. It can be heard in coronary artery disease. This can be heard in congestive heart failure. Okay? With this background, true about heard in MR, yes. Diastolic sound, yes. High pitch, no. Low pitch, normal in children. So answer is A, B, and D in this case. true about Myasthenia Gravis. Let's learn the basic concept about Myasthenia Gravis. Myasthenia Gravis, but before I discuss this question, stop the video, write down the answer. Tell me which age group is involved, male, female. What is the most common age group involved in Myasthenia Gravis? Stop the video. Well, the right answer is females 20 to 30 years, males 50 to 70 years. Something very paradoxical. Normally, it usually doesn't happen. That means the lady will come in the young age and the gent has to come, it will come in the elderly person. Okay, point to be noted. Now, it's a disease of the myoneural junction. Basic concept. This is the nerve ending and this is the muscle and these are the receptors. This is the presynaptic, postsynaptic. From here we have vesicles which contain acetylcholine. They come and they get released and they act in the receptors. And this is how muscle contraction starts. Now in this disease there are antibodies against these receptors. So acetylcholine will definitely come, but this receptor have been blocked by the antibodies, so this acetylcholine will not be able to act on this receptor and that lead to muscle weakness. Typically evening fatigue is the most common presenting feature. The patient will get unnecessarily very severely exhausted in the evening hour as compared to his fellow colleagues, and he may have weakness, and ptosis is one of the common features of this condition. Proximal muscles are more commonly involved, and bulbar muscles, that can lead to dysarthria, diplopia can occur. And one more classical finding, eye muscle involvement is a feature. Okay, this is a very, very important point, and one of the early diagnostic feature is check for the acetylcholine receptor antibody. It's the best initial test. And other antibody that we can see here are MuSK antibody. In some patients, thymoma may be there. It may or may not be there. With this background, we talk about the question. Defect at the myoneural junction, yes, this is true. May involve young ladies and older ladies. It is usually older males is the answer. 28. Older. Okay, young males and older ladies, this is not the answer. It's the other way around. Acetylcholine receptor antibodies, true. False. Thymoma occur, true. Autoimmune antibodies, true. So true is A, C, D, and E. Question 29. False statement about extraadrenal pheochromocytoma. Well, before I discuss see the question, let's talk about pheochromocytoma. It's a tumor of chromophene cell. %10 are malignant. Rule of 10% are extraadrenal. Okay. 10% occur in children. The rule of 10 occurs. Pheo is a highly vascular tumor. So that's why we never do FNAC in this case. FNAC is absolutely contraindicated. Right? And the most common feature is headache, profuse sweating, and palpitation. This is the classical triad of this symptom in this case. And in this case, when you check the exam in the urine, you can see meternephrine. Meternephrine is nothing but a byproduct of epinephrine and norepinephrine. So with this background, let's talk about question. False. What is false about this condition? False is extrarenal 10%. No, it is only not 50%, it's only 10%. This statement is false. Then the next option is may occur in bladder, yes. May occur in thorax and may involve carotid body also. Hence the answer is A in this case. Okay? Microcytic hypochromic anemia is seen in all except. Let's learn the basic concept. Well, this one question is there. Suppose a patient of anemia come to you. Write down the answer. What is the anemia patient you are suspecting? And I ask you to do only one test. What is the best initial test to diagnose any case of anemia? What test you would advise? Write down the answer. Well, I am sure you have written the answer. Answer is always go for peripheral blood film, the best initial test. What is the importance of this? You check for RBC size. Normal RBC size is between 80 to 100 FL. If it is below 80, we call as microcytic anemia. If it is above 100, we call as macrocytic anemia. And if it comes in this range, we call as normocytic anemia. Microcytic hypochromic anemia we seen in iron, microcytic anemia in particular, we see in iron deficiency anemia, we see in thalassemia, we can see in lead poisoning, and we can also see in advanced stage of sideroblastic anemia. Normocytic is typically we get in anemia of chronic disease. It may occur in some case of chronic renal failure. Macrocytic anemia we get in B12 and folic acid deficiency. With this background, let's look into the question. Microcytic hypochromic is seen in which condition? We see in iron deficiency, sideroblastic, lead poisoning. And we do not see in sickle cell and we do not see in hereditary spherocytosis. Rather here we get sickle type of cell and where we get a sphere type of cell, so there is no question of microcytic. Well, two about rheumatoid arthritis. Let's learn the basic concept. The basic concept goes like this. Rheumatoid arthritis. It's a disease more in females. HLA-DR4 is involved. The disease starts from cartilage. It starts from synovial membrane. Ultimately, it involves cartilage. And it may involve the bone. And that can lead to bone destruction. So we can say and that lead to bone destruction and bone deformities also. That's why we call it to be erosive arthritis. Erosive arthritis typically involve the small joint of the hand. It may involve wrist, elbow, knee. But the only part of vertebra what involved is cervical spine. Lumbar vertebra is never involved. That's why low backache is never a symptom of rheumatoid arthritis. Low backache occurs in ankylosing spondylitis. With this background, disease limited to cartilage? No way. It involved bone also. False. HLA-DR4? True. More common in female? True. Extra-articular? True. hand elbow is more affected, true. Okay. The true about is, the false is, A is the one which is false in this case. Rest all are true. Question 32. Hypoparathyroid can occur due to, let's learn the basic concept. Well, causes of hypoparathyroid. It can be idiopathic. Idiopathic variety is the one which is usually autoimmune. In this what in actually clinical practice, this type of patient what we see. Second cause of hypoparathyroid is surgery. Maybe thyroid surgery or head and neck surgery, where typically in thyroid surgery, of course in head and neck surgery also, where they remove the thyroid and by mistake they can remove the parathyroid also. It may be a part of DiGeorge syndrome. It's a congenital defect where patient has hypoparathyroid and there is thymus aplasia, thymic aplasia, right? And with this background, if you look into causes of after thyroid surgery, true. DiGeorge syndrome, true, true, and MEN1. In MEN1 is not the answer because here we get adenoma. Adenoma that lead to increased PTH, and this lead to increased PTH, and that lead to hypercalcemia. So in MEN1 it is not seen. Answer ABC. Again, I think there is some typing error in the answer key. You can please correct it. 32 is A, B, and C are correct. Now let's talk about question number 23, subarachnoid hemorrhage. Let's learn the basic concept about. As far as subarachnoid hemorrhage is a VVIP topic. In every exam you get a question regarding subarachnoid hemorrhage. What the most common question or most common clinical presentation? Most is sudden headache, never experienced before. Sudden severe unbearable headache, never experienced before is the most common presentation. And the most common cause is trauma. If trauma is not the answer, then you go for Berry aneurysm is the next best answer. And in this case, when you do, the best initial test is non-contrast CT scan. And this is positive in around 95% cases. In 5% cases, it may not be positive. Then the most accurate test is lumbar puncture. In lumbar puncture, we can see fresh RBCs if it is done immediately, or if it is done after 6 hours later on, then there may be hemolysis, and that can lead to xanthochromic CSF finding will be there. Okay. With this background, let's talk about the question. The answer is CT scan has 95% sensitivity. This is true. It's never 100%. Lumbar puncture shows xanthochromia, true. And 10% of SI caused by rupture of AB malformation. This is more because most if the trauma is not a cause, then most of the things they occur due to rupture of this, not 10% more. And as far as the rebleeding can occur in around 20% cases, and that carries a poor prognosis. Okay. And most common cause is sacral aneurysm is a wrong answer. Trauma is the most common cause. Okay. Let's talk about what are the other complications which can occur in the SAH. The complication which can occur is vasospasm, and this is the most common cause of delayed morbidity and mortality. That's why we use nimodipine. The next question was vasospasm. I told you vasospasm can then bleed. which carries a very poor prognosis. Patient can develop SIADH, which can lead to hyponatremia, and patient can develop hydrocephalus. There are some of the complications of case of subarachnoid hemorrhage. Now I'll be discussing question number 34. Drug causing scleroderma. In fact, in this, the question is being asked, which of the following drugs they lead to thickening of skin, because in scleroderma, thickening of skin occurs. And this is caused by drug A, B, and C. So now let's see what are the other options that we have. One of the options is corticosteroid. Okay, CS stands for corticosteroids. It doesn't lead to thickening of skin, rather it leads to thinning of skin, and there can be bruise. Can be there. Okay. Otherwise, overall appearance is concerned in the face, it gives rise to moon-like face. But this moon-like face is primarily because subcutaneous deposition of fat is the reason. But it definitely doesn't lead to thickening of skin. And regarding tetracycline, it has got no thickening effect on tetracycline also, right? So it's a straight factual question is there. There is not much of concept in this question. Question 35, which of the following is true regarding asthma and COPD? First of all, as you are well aware, COPD is one disease which is a irreversible disease. In contrast, asthma is a reversible disease. Now let's see. COPD shows less reversibility to bronchodilator, while asthma shows significant improvement. This statement is definitely true. Asthma is a gradual progression of dyspnea on exertion, punctuated by acute exacerbation of shortness of breath. While most COPD patients have normal breathing, not at all. This is wrong. COPD is rather a chronic type of cough, and asthma is more of a episodic phenomena. So in this question, if we have to talk about, okay, the option of this question is A is the answer, and the second is C and D. Let's discuss these points, A, C, and D. As far as option A is concerned, I am talking to you. A, C, and D. C, COPD patient have acute exacerbation, while asthma patient have recurrent episode is again true. One of the hallmark of asthma is reversibility. So let's talk more about asthma now. Asthma is a triad of dry cough, dyspnea, and wheeze. After this is the earliest manifestation. This one is the most common manifestation. This is the most characteristic manifestation. And one of the hallmark which I discussed earlier also is of asthma is reversibility. Reversibility. And most of the time, especially atopic type of asthma, it is due to allergic phenomena. And the cells which play a very important role in the pathogenesis of asthma is eosinophils. Eosinophils, they reach the bronchi, and they release a lot of they release a lot of transmitter, and they lead to bronchospasm. Okay. In contrast, COPD is concerned. COPD is primarily due to infection. It's an infectious disease, and there are three most common organisms which are involved in the pathogenesis. Stop the video, write down the answer. Which are the three organisms which are the key cause of infection in COPD? Write down the answer. Well, I'm sure by now you've written the answer. Answer is the three most organisms are common are strep pneumoniae, H. influenzae, and Moraxella catarrhalis. There are three main organisms which cause all this thing. Now, in this case, there is mucus secreting gland get enlarged in COPD. The mucus secreting gland get enlarged and they produce large amount of sputum. And this is enlarged mucus gland that we call as reed index. Let's learn the basic concept. What is the reed index? This is the wall of the bronchus, and here we have a bronchus secreting gland. Let's presume this thickness is 4 millimeter, and this thickness is 1 millimeter. So now the ratio of mucus secreting gland to the wall of thickness is 0.25. Now, as I told you, one of the characteristic feature of COPD is this mucus secreting gland, they enlarge. Suppose this gland size is now 2, the ratio will become 0.5. It enlarges more, 3.75. So this is called reed index. The reed index is increased in case of COPD. So by now things are clear to you that asthma is more of a antigen antibody phenomena. That's why corticosteroid play the most important role in the treatment of asthma and COPD, because this is an infective phenomenon. So antibiotic have the most important role, not these steroids. Okay, so this the main role is in every case of chronic bronchitis in particular, antibiotic, unless you give antibiotic, patient will not get cured because you have to treat the root cause of the disease, that is infection. I hope things are clear to you. Now we talk about question number 36. What the changes that you get in pulmonary embolism, this thing I discussed in the previous question, so I don't think I need to repeat again. We get ST elevation. We get ST elevation in this case. Why we get? Not due to, what's the reason why we get ST segment elevation? 36. Because as I told you, we are getting right bundle branch pattern is there, so that can lead to. So in this case, T-wave inversion in V1, V2, yes, this is all due to secondary to right bundle branch block. S1, Q3, T3, yes. Left axis deviation, no, there is right axis deviation because the right bundle branch pattern can be there. So what you get in this case is, in case of ECG finding in pulmonary embolism, I discussed earlier, tachycardia is there. Some cases we can get bradycardia also. What we call as paradoxical bradycardia is seen in pulmonary embolism. You get right bundle branch block pattern. That is, you get M pattern in V1 and W pattern in V6. Those we get ST segment elevation in V1, V2, and there is right axis deviation is there. Left axis deviation is not a feature of pulmonary embolism. Question 37. All are true about insulinoma except. The answer of this question is C, D, and E. Okay. C, it is associated with MEN2. No, it is not associated. Benign lesion with no malignant potential. It can be malignant also. More common in head of pancreas. This again not true. The true are what we think is A and B are true. Okay. Symptomatic hypoglycemia may be present, and that's the reason why we call as Whipple triad we get in these cases. So in insulinoma, there's such a thing very special to more. Is first of all, insulinoma is a neuroendocrine tumor. In fact, it is the most common neuroendocrine tumor of the pancreas, and it secretes large amount of insulin. And that, because of a large amount of insulin, that leads to hypoglycemia, very frequent hypoglycemia. And this hypoglycemia leads to increased appetite. And this increased appetite, patient tend to eat more. And that's why patient tend to have weight gain. Something very interestingly, most of the time cancer, they lead to cachexia and weight loss. But this one cancer which classically weight gain is a feature is a very frequently asked question. Okay. Now one more thing. This can lead to hypoglycemia, and that we diagnose by a Whipple triad, and it's a symptomatic hypoglycemia occurs. Now I have a question for you. Suppose I get to one patient, I give insulin. By the treatment, we give insulin, that can also lead to hypoglycemia, and we have one patient which can also lead to insulinoma patient which can lead to hypoglycemia. Now what test you will do to differentiate? Only one blood test I ask you to do to differentiate these two conditions. Stop the video, write down the answer. Well, to differentiate between the two, you should check C-peptide level. C-peptide level. Remember, some of you may have answered 72-hour that's the insulin test, okay? That's the most common wrong answer. 72-hour blood sugar checking we do to diagnose insulinoma. But here, the question is to differentiate between insulinoma and exogenous steroid, or exogenous glucose, insulin. We use C-peptide. Because what the basic concept behind that, let's learn the basic concept. The basic concept goes like this. In endogenous insulin, which is secreted from pancreas, is in the form of proinsulin. Proinsulin. It breaks down into insulin and C-peptide. This in the portal circulation. In contrast, so that means there will be equimolar insulin and equimolar C-peptide in endogenous insulin. But in contrast, exogenous, so only insulin will be there will be no C-peptide. So if you are getting equimolar C-peptide, we are dealing with insulinoma. So to differentiate between exogenous and endogenous insulin is C-peptide. Okay, I hope things are clear to you. Well, now we talk about question number 38. Drugs used in thyroid crisis, we use A, B, E, C and E. We do not use aspirin. What is the idea? Why we use all these except aspirin? Let's learn the basic concept. Well, thyroid crisis means there is excess of thyroid hormone is there, and we know very well T4 is the main hormone which comes from thyroid, but main active hormone is T3. Active hormone is T3, and 80% of T3 is made from T4 in the peripheral tissue via deiodinization. 80% of T3 is made in the peripheral tissue. Okay, so now there are certain drugs which inhibit this T4 T3 conversion. The drugs which inhibit the conversion are: number 1, dexamethasone; number 2, propranolol; third, high dose of iodine; 4, propylthiouracil. Okay, propylthiouracil. These are drugs which inhibit T4 T3 conversion. So that's why when we are thyroid crisis there, we want that less and less T3 should be made. We use all these drugs which will inhibit T4 T3 conversion. So I hope, and aspirin has no role to do in this. Aspirin doesn't have this quality of inhibiting T4 T3. Righto? So this was regarding question number 38. Now we talk about question number 39. All are true about pheochromocytoma except 39. Okay, 90% are malignant. No, only 10% are malignant, and rest all are correct. So let's discuss this question regarding pheochromocytoma. We all know pheo is a tumor of again neuroendocrine tumor. Chromophin is a tumor of chromophin cell. And rule of 10 applies. 10% are malignant, not 90%. 10% are bilateral. 10% occur extra-adrenal. The three most common symptoms are headache, palpitation, and profuse sweating. They are highly vascular tumor. So that's why FNAC is never done. Because if you put a needle, patient will bleed to death. And of course, patient has episodic hypertension, so-called paroxysmal hypertension. And one more thing which is not known to most of students, that this patient have, this is known to all of you, but one additional thing that you should know is, in this case we get postural hypotension. Postural hypotension, okay? And of course hypertension is the most common sign, and the symptoms are headache, palpitation and sweating. And of course in this case when you check, you get methamphetamine. Methamphetamine is nothing but a byproduct of catecholamine that we can see in urine. And of course when we are treating in this case, we never give beta blocker as a first line treatment, never. We first give alpha blocker, then we can give beta blocker, because if you give beta blocker alone, it will precipitate severe hypertension. Or we can give a drug having both alpha and beta blocking action like labetalol. But final, most definite treatment is surgery. You remove the tumor, and one of the most immediate side effect of surgery is hypotension. Hypotension is the immediate side effect. That's why when we are trying to remove this tumor, the patient has to infuse large amount of IV fluid soon after removal of the tumors to prevent this catastrophic problem of severe hypotension. Now we talk about question number 40. In menetrier disease, the true about is, it's a increased gastric acid secretion. No, this is usually they have a hypo, that means less secretion of acid. Protein losing enteropathy, it can occur, yes. Mainly affect body and fundus, yes. No malignant potential, it is not there. And transforming growth factor is overexpressed, yes. So in this, in fact, except A, all are correct. There is some error in the answer key, please correct it. In this case, A, B, answer are B, C, D, E. Answer is B, C, D, E. Now, in this case, the problem is this the gastric, a lot of folds are there, and there's a foveal hypertrophy. And this primarily affect body and fundus. And in this case, usually acid level is reduced, usually, most of the time. And in these patients, and this we can best diagnose by endoscopy, and we can take a biopsy also. And these cases, protein losing enteropathy can occur. And that lead to large amount of protein loss, and that will lead to edema of feet because of loss of albumin in the body. Now I have a question for you. It's a rank number 1 question. Now there are many GIT conditions which can lead to protein losing enteropathy. There is only one cardiac condition which can lead to protein losing enteropathy. Stop the video, write down the answer. The question is, which cardiac condition can lead to protein losing enteropathy? Well, I'm sure you have written the answer. The answer of this question is constrictive pericarditis. Can lead to protein losing enteropathy. Constrictive pericarditis can also lead to nephrotic syndrome, and it can lead to protein losing enteropathy. The body is losing protein not only from kidney but also from GIT, and that lead to severe hypoalbuminemia and they to generalized edema. Here again, pericarditis thing, ascites is much more than the edema in the feet. Spleen may enlarge. So clinically, constrictive pericarditis may resemble like cirrhosis of liver. Exact manifestation, spleen enlarged, ascites is there, and that's the reason it is the DD of cirrhosis of liver. But here the question was, which cardiac condition can lead to protein losing enteropathy is constrictive pericarditis, is the rank number 1 question. Okay. Now, question number 41, which causes reverse splitting of second sound? Okay. So let's talk about second sound. Second sound, normally A2 come first, P2 come little later on. Okay. So single S2 Single S2 occurs in tetralogy of Fallot. It also occurs in tricuspid atresia. Then we have wide and variable splitting. Of second sound. This we see in right bundle branch block and pulmonary stenosis. Wide and fixed splitting second sound. This is seen in ASD. Then reverse splitting of second sound. That means where P2 come first, A2 come later. This is seen in left bundle branch block, and this is seen in severe aortic stenosis, and we also see in WPW syndrome type B. What is type B? Let's learn the basic concept. We know very well that in WPW syndrome there is correction between atria and ventricle. If it occurs between LA and LV, we call as type A. If it occurs between RA and RV, this is called as type B. The reverse splitting is seen in type B, but in type A, its reverse splitting is not seen. So this is regarding second sound. And so causes, so when we are talking about reverse splitting second sound, the answer 41 shall be B, and answer shall be E. E and B are the answer to this question. So this is all about medicine question. I hope you learned many more new points in addition to what you knew earlier, because one more thing, when we discuss this question, we have a very limited time to talk, but still I try my level best to give you many more extra points. And just to inform you, I have recorded my Medicine e-Gurukul, which is available on our website, and it's a fully updated lectures from based on Harrison 20th edition. If you want, you can take it, and if you see that, more than enough. And of course, my Medicine Simplified is the ultimate book based, so-called mini Harrison will also help you in preparing your exam. Wish you all the best for all your exam. Thank you very much for watching this video.